This whole thing, the registry all started about 10 years ago when our high performance group met and we had been discussing different regenerative therapies for various injuries. And I thought, well, here we have all these top end veterinarians. Why don't I just survey them and I'll figure out what the best products are? And it was amazing. There was like zero agreement about what to use on a bowed tendon, a suspensory, what have you. And then shortly after that, I was working in Florida on a really nice horse that had a soft tissue injury, and the owner was Ann Lindblad, and she's a PhD biostats person who's actually gotten involved with this group. But she was asking all the right questions, like, so what is the likelihood of this horse coming back? And I'm like, well, I mean, I have my opinion, but I don't really have a lot of data. She said, oh, that's interesting. Okay, well, which product should I use? Which one is the most clinically effective? And I'm like, well, I have my experience, but I don't have any data. And this went on for a little bit of time. And she came back to me and said, Mark, you guys need to do a registry. You guys need a registry. You need to be able to get big case numbers of real life, competing athletes, not herd animals, and compare them across the board. And a registry is different than a traditional study, but it will be tremendously valuable to you. And so that started the process, and it's been a crazy process. And we're here today. Mike is a legend, I've got to say. The vet he's married to worked in our practice for a while, and we were trying to get a biostats person to help us interpret this stuff. And I called him and he just volunteered and said, hey, wow, that sounds really cool. And he has helped us tremendously in interpreting some of the information we've received. So from there, can we go to the next slide? I don't know who's controlling it. There we go. So uh, regenerative medicine is evolving faster than the science supports it, that is supporting it. So it's interesting. The science part is really coming on strong recently, which is great. But we still need, as the people out in the trenches, we need real world safety numbers, not safety numbers from the company producing the product or the kit. So kind of a third party safety assessment. And we need efficacy. We need big numbers and we need a consistent study design. So we're not, we see a study on 10 horses that had a iatrogenic injury versus 15 horses that had a different kind of injury. Makes it really, really difficult to be making decisions about choosing one product over another. Then it gets compounded by different disciplines. And then different veterinary practices. There's a lot of variability on how things are done in the real world. So next slide. And so here it is. We call it the ECR, the Equine Clinicians Registry. So it's a prospective compilation of demographics, specific sport injuries, and outcome parameters following orthobiologic interventions. We now have a cloud-based, anonymized system we have developed outcome parameters that we believe are fairly universally important. It started officially in 2021 as a proof of concept study, and that proof of concept, the outcome is what Mike is going to be presenting on here today. And then I just bring attention to the fact that this is actually our official iteration now is in 2025, that we're studying suspensory ligament injuries exclusively to get a bit more specific about our outcome parameters and injury descriptions. Hopefully 2026, we're going to do another version which will involve joint injury. So next one, I'm about done. Yeah, so this is really important. There've been two huge hurdles in this process. One is conveying the fact that a registry is different than a double-blinded study. And I think we've all come to expect that if it isn't a double-blinded study, it has no value. Um, uh, I think Bo is going to address this again at the end, but it's a really, really important point. Our expectations are different for a registry than they are for a double-blinded study. They each have their strengths and their weaknesses. But the biggest hurdle of all has been compliance. And so those who have been involved with it will speak to the fact that it needs to be simple. Otherwise, it doesn't get done. And so we've had to walk this line between being thorough but not being so exhaustive that no one actually fills out the darn thing, because then you got nothing. Next slide. And then, yeah, so this is the end of it here. We have a fantastic advisory group. You've already heard from Lauren and Kyla, but also Mindy Story at CSU, and then Ann Lindblad, who is the biostats person that I referred to earlier. But really, at this stage, Mike really has carried the biostats component of it amazingly well, and has had a great outside perspective. He's not as deeply entrenched in the equine veterinary world as the others, which gives him a little bit of a fresh angle on it. And he's come up with quite a few things that I think we might have overlooked otherwise. So, with that, I think we're going to hand it right over to Mike.
Yeah, thanks, Mark. So like Mark said, my name's Mike Forsley, and I kind of took the data from the pilot study and did some preliminary analysis and exploratory analysis just to kind of come up with a proof of concept and try to demonstrate the methodology and see if there's a way forward. So starting off, I'm just going to go over kind of the data that were actually collected on a really basic level, starting with just basic patient and practice numbers. So the y-axis of both of these figures shows a cumulative count through time, and the x-axis is just a year. The top panel shows patients, the bottom panel shows practices. The main takeaway was that the data I was working with for the pilot study covered about 440 patients collected from about 10 practices. The registry also includes a lot of baseline demographic information for each patient. Like Mark said, we're using observational data. This isn't a randomized trial, but we can account for things like patient age, patient breed, patient discipline in our modeling, so long as we have those data. So things like patient age on the x-axis here with just a basic count on the y-axis. And I just wanted to kind of show the basic distribution of patients in the registry. The median age was about 9 years old. And you can see there's a big spike of 2 to 5 year old horses, which are this big group of cutting quarter horses that were a big part of the data set from one of the practices. The registry also includes patient discipline. Again, we see the cutters at the top, but there's a handful of other disciplines represented as well. And then probably most pertinent to this group were at the initial exam for each patient, there was a treatment type which was recorded and tracked as well. Another really important explanatory variable for the modeling down the line was injury severity. You can imagine if we're trying to understand or model the efficacy or the recovery rate of patients treated by different treatments, the underlying severity of the injury is a really important explanatory variable to account for. But like Mark said, there were things highlighted in this kind of preliminary analysis that really helped kind of refocus the next stage on which things are really important to highlight for practitioners to be really careful with entering their data. And injury severity is a big one that we'll talk about again down the line. But you can see that well over half, probably the majority of the injury severity data were missing. And again, this gets really important when we try to stratify. So if I want to model the recovery rate of patients by different treatments, I want to include that severity metric as an explanatory variable because otherwise there's some obvious confounding. This figure shows severity from mild to severe with missing on the far right of the x-axis, and then a handful of different treatment types on the y-axis. And again, I just kind of want to point out this far right column. If we look at the lower right-hand corner, the dark red block, that's saying that 71% of our severity data are missing for patients that were treated with A2M. And it's a pretty similar story going up that far right-hand column, which again, it just make things a little difficult down the line when trying to account for potential confounding. So I'm just going to go over some really basic follow-up outcomes. I may be saying this is out loud just for myself, but just to reiterate, the underlying data in the registry were basically demographics, information about an initial visit for each patient that included the treatment type, severity, all of those other things. And then each patient had one or more rechecks. So the median time to first recheck was about 1 month. But you can see on this figure, so the x-axis here is the months to first recheck for each patient in the registry, and then just a count on the y-axis. The black line shows the median of 1 month, but you can see that we've got most patients in for their first recheck in the first couple of months. There were a handful of patients with no rechecks, which, those data are then not very useful to us, but the range went from 0 to 12 months. The median number of rechecks per patient was 3. Most patients had, 10 or 1 to 10 rechecks. There was one patient with about 50 rechecks, which is hard to comprehend. But if you just kind of focus on the distribution on the left side of this figure, we can see that most patients are getting at least a handful of rechecks. And it's that pairwise pairing of the initial visit with rechecks. Multiple rechecks are better. That really give us the ability to model kind of the recovery of patients by different variables. So the modeling I alluded to was, it was really exploratory. And again, it was mostly meant to just demonstrate the potential of the methodology. Can we build a registry from data collected in the day-to-day operations of an equine clinic and then use those to make inferences about, the recovery of different patients across whatever explanatory variables we want. We used what are called Kaplan-Meier and Cox proportional hazards models. And what we can do with those is calculate the probability of recovery for patients across whatever age, treatment type, severity, any different demographic variables, any data that we have can be incorporated into those models. So just to kind of start off with a really basic model output to just kind of explain how these models work. The y-axis here is the overall rate of patient recovery for patients included in the pilot study. And then the x-axis is the number of months. And you can see that the black line increases slowly through time as the probability of recovery increases for patients included in the study. The vertical bars are 95% confidence intervals. So they're just basically a measure of statistical uncertainty and statistical error. The reason the bars grow larger on the right-hand side is because fewer and fewer patients, once we get up into 9, 10, 11, 12 months, our sample size diminishes because most patients are having their rechecks within the first 6, 7, 8 months, which is why, months 0 through 3 have really small confidence intervals, and that's where the inference is the strongest. In addition to just that probability of recovery curve, there's other statistics available from these model outputs. So we can do the probability of recovery at any time along the curve. So something like 50% of patients recovered by 5 months. We can get a median time to recovery, which would be the median time to recovery for patients with these values of our explanatory variables was 5 months. And then, probably most useful is what's called the hazard ratio. And that's where we can make inferences about variables included in the model. So like patients treated with treatment A recovered 1 times faster than patients treated with treatment B. And then again, all of these statistics come with measures of uncertainty and error, which are useful because it helps us understand kind of the strength of our inference. So we've seen this like basic single survival curve where we're just using no explanatory covariates. All we're doing is just modeling the rate of recovery for patients in the study, and that's not super useful. But what we can start to do is incorporate explanatory variables. And so this is a real model from the pilot study data. It's the same figure with rate of recovery on the y-axis and months on the x-axis, except I've just included an explanatory variable saying, are these joint injuries or soft tissue injuries? So we've got rates of recovery based on a really basic 2-level explanatory variable. I've hidden the confidence intervals here because as we stratify, this is a small pilot study. As we stratify even into 1, 2, or 3 explanatory variables, our statistical inference, is weakened. There's a lot of overlapping in the confidence intervals between the 2 lines. But the fact that there are discernible trends here is kind of what we were looking for just demonstrating the method. A really cool one, again, just using one explanatory variable, was just recovery by age. So the dark blue line at the very top are the youngest horses, and the light blue line at the very bottom are the oldest horses. And then there's different curves for ages in between the oldest and the youngest. And again, just trying to demonstrate the methodology, we can include this age covariate, which is super important if we want to look at things like treatment type, but still be able to detect discernible trends at this stage in the process. We were able to kind of tease out some trends even by treatment level. I've got the treatments anonymized here, but again, just wanting to demonstrate the methodology and just show that we're able to see some trends. We can already kind of differentiate by treatment, and then take it one step further even and combine treatment and age. So the top panel shows one treatment anonymized, the bottom panel shows a different treatment anonymized, and then each color, blue, green, orange, I guess, shows a horse of either age 5, 10, or 20. And we're able to detect both differences in the recovery curves by treatment, but also account for that potentially confounding covariate of patient age. So I wanted to note the severity. Again, this is what it looks like when you have really incomplete variables or really incomplete data for a really important, potentially confounding variable. So once we start stratifying by 2 or 3 explanatory variables, right, like where our sample sizes for each group get smaller and smaller, I just think this figure really exemplifies the need for like focus by practitioners when entering the data. But we're like currently really unable to stratify by severity. This would show the recovery for a specific treatment stratified by severity, and you can see that we've got each dot is basically an observation in our data set, and we've got a very limited ability to even build like a basic model by including the severity covariate, but we know we can do it as we accrue more data, which is kind of the point. Okay, so really quickly, I keep saying as we accrue more data, we'll be able to hopefully stratify by 2 or 3 or even 4 explanatory variables at a time. And we can demonstrate the methodology further just by simulating those data. So I took our pilot study data set. I basically built an algorithm that added X amount more data to it. And then I can rebuild these models just to try to get an idea of, or to give people an idea of what a really potentially useful future model output would look like. So this shows a patient of age 6 years old on the top panel, a patient of age 20 years old on the bottom panel. The solid lines are treatment 1, the dashed lines are treatment 2, and then we've got 3 different colors for low, moderate, and severe injury, low, moderate, and severe injuries. Again, these are simulated, so we don't want to like look too closely at this. It doesn't really matter. The point here is just to demonstrate that in the future, we'll be able to tease apart things stratified to 2 or 3 or 4 levels, and things can start to get really useful. So just again, the takeaway from the preliminary modeling was I think that we clearly demonstrated the efficacy of the methodology. The 95% confidence intervals and all the statistical uncertainty definitely highlights the need for more data. We've highlighted the need for very clean data, especially for potentially very confounding underlying variables like injury severity. And then we have some simulations that I do think provide evidence that our statistical power and the usefulness will increase as we accrue more data.
All right, thanks, Mike. Yeah, this is a little pie chart I made up, and it does not reflect necessarily my own use or maybe any of y'all's. I kind of exaggerated some of them to make a point, but just thinking about how equine vets in general decide what we use. There in the blue, which is put as just the largest portion, is anecdotal experience. So, I have a fetlock and a barrel racing horse that has moderate OA. I'll put some PRP in it. The horse gets better. I do a couple more. They all get better. And so start using PRP in fetlocks and barrel racing horses, just as an example. And so I think this predominates a lot of how we practice, just based on clinical experience, what responds to what, kind of seeing is believing. I think that the next largest group often is other people's anecdotal experience. Say I've got a jumper with a check ligament injury. I call up Mark. Hey, Mark, I've got this horse, with this check ligament. What would you use? He's like, oh, I'd use this product. It's been working good for me, so I try it and use it. So I think that happens pretty often when we call up other veterinarians and just get their experience, people we trust. Next, we have peer-reviewed research, which is great. We have quite a bit of it that we can use. The problem is it typically just compares one product to a control group. And so it can demonstrate efficacy and safety, certainly, but doesn't always help us decide when to use one product over another. We have research data that can be provided by companies. Oftentimes this is safety data. It tells us what's in the product. Sometimes they will have research projects as well. They can give us some insight on that product and when to use it. There's client preference too. So I'm sure y'all have all had this experience where you have a client come in and they're like, hey, I got PRP in my knee a year ago and it's felt great since. I want you to put PRP in my horse. And you're like, okay, fine, let's do it. So that happens sometimes as well. And then we have clinical data comparing products against one another in the green there, but you'll notice there's no green in the pie chart. And why is that? Because we don't have that data. And so that's what we're trying to achieve here. We want some green in that pie chart. Ideally it'd be the biggest part of it, where we really know what product to use in which situation. And that's the goal of what we're trying to accomplish here. All right, Mike, go to the next one. All right, so why are we doing this? Mark's alluded to some of this before. Clinical trials, double-blinded trials, they're great for giving us, really good data on product safety, on product efficacy. But, sometimes we're not asking the questions because sometimes we don't know what to ask. And that's one thing we found from that first study was we found answers to things that we didn't even know we had questions for when you start going through the data. That's really interesting. So you'll start gleaning things out of this data that you wouldn't even have known to ask in the first place. You don't have a hypothesis. You don't start with a question like you do with a traditional clinical trial. You just start gathering data and kind of see what comes out of it. Study designs are of course quite different. The registries it's very observational, not interventional. Reflects clinical practice as opposed to where you're going to have more of a controlled environment. There is going to be some bias risk in medical registries because there's bias in general practice. And certainly that can be controlled for somewhat in a clinical trial. But we do want to reflect really what's happening in practice. And that's going to come with some bias as far as products used and things like that. As far as the data we get out of it, Mike has already gone through some of that, showing the kinds of data that we can get. It's going to be variable. There's going to be a lot of variation to it, but hopefully we'll get some pragmatic endpoints that'll help us make some decisions in the real world.